All right, I think we've reached critical mass and we're at 2 minutes past the hour, so I'm going to get started. Welcome everyone to our first day of March and to our webinar, Impact of Information Blocking Rules on Health Information Exchanges. We're thrilled that so many of you are with us. I am thrilled with our group of panelists. And this is clearly a very timely topic and one of great interest to all of you, given the robust audience we have. So this should be a treat. A few housekeeping notes before we dive into the presentation. This webinar will be recorded and it will be posted in the eHealth Initiative Resource Center some point in the next day or so when we conclude. And we'll also hold some time at the end for questions. So if you have any as the presentation is proceeding, please type them into the Q&A box and we'll do our best to get to as many of them as possible at the end. And finally, I will say a little bit about EHI to get us started. The eHealth Initiative, I'll do our agenda first and then we can talk about the eHealth Initiative. We're going to start with welcome and introductions. I'm Alice Leiter. I'm a Vice President and Senior Counsel at EHI. And then we will launch into our panel discussion, which I'll moderate. And I'm joined by an illustrious group of panelists, Devin McGraw, Adrian Ellis, Melissa Cotrese, and Amy Warner. I'll have each of them give a little bit of a more detailed bio and talk about their work. And then we'll hold time at the end for questions and answers. Answers, really, hopefully. Here's what we all look like in our titles. And we really want to say a special thank you to Citizen, which is sponsoring this webinar. We couldn't do this without this wonderful organization and Devin McGraw in particular. A little bit about EHI's work. Hopefully many of you are familiar with us. We focus our work in the areas of education, advocacy, and thought leadership. You can see underneath these some of the ways in which we do this. We have a fantastic group of members. You can see their names here. If you're interested in joining EHI and you haven't already, please visit our website. And currently we're focusing on four main substance areas: consumer privacy, virtual care, analytics, social determinants of health, and artificial intelligence. And of course, COVID-19. No health organization is complete without a COVID focus these days. And here is some upcoming dates of events that we're hosting, upcoming webinars, upcoming work group meetings, and an upcoming roundtable. Again, if you visit our website on the events page, you can see a full list of everything we have coming up and view videos from the events that have already occurred in recorded format. Some of those include the SDOH impact on equity and diversity in clinical trials. We released a consumer privacy framework for health data last month. Virtual care, patient matching, COVID, access to healthcare delivery, really anything that you could possibly be interested in, I think, is up there on the EHI site. So please visit us. And we're very, very grateful that you're here once again. So on to the main event. I will stop sharing my screen so that you can see. Hopefully that's working. Yes? Okay, great. Today, as you know, we're talking about the Office of the National Coordinator's Health Information Blocking Rule, which was finalized last year, but it has an upcoming compliance date. It's just around the corner. So again, very timely, and the implications of this rule and impact on health information exchanges. As I said, and as you saw, we have an all-star cast of panelists. We have Devin McGraw from Citizen, Melissa Cotrese from Health Current, Amy Warner from the Rochester Regional Health Information Organization, and Adrian Ellis from CRISP. So I will call on each of them and ask each of you panelists to say a little bit more about yourselves and the work you do, and then give us any overarching thoughts on this rule and the effect that it's had on you or how you and your colleagues received it. We'll start with Devin.
Okay, thanks a lot, Alice. I'm really pleased to be here and pleased to see the number of people who have joined us on our webinar. This is fantastic. Obviously, there's an important set of issues. So I'm a co-founder of Citizen and also its chief regulatory officer, and we're a platform that enables patients to gather all their health information so that it's and to have it organized for them so that it's at their fingertips and they can use it and share it in ways that are important to them. We're focusing on very sick patients to start, patients with cancer, and recently added rare neurological disorders. And so obviously we're very interested in these rules because of the potential to open up avenues for patient access to data beyond the sort of typical ways that patients are able to get their data today. But we're also interested in this because in December, we purchased the assets of a company called Stella Technologies, which many of you may be familiar with, which provides technology and services to HIEs through gateway software, through quality data software, including Prism and IQ'd. So we're also very interested in helping HIEs comply with this rule. So we're kind of coming at this issue of information blocking really from a number of angles. But super glad to be here with a great all-female panel for Women's History Month. It's a good way to kick it off.
Happy Women's History Month. Thank you, Devin. Melissa?
Thank you. Good afternoon, everyone. I guess good morning if you're on the far West Coast, but at least it's a little afternoon here in Arizona. I'm Melissa Cotrice. I serve as the CEO at Health Current. Health Current is the statewide health information exchange in Arizona. We have grown significantly over the last 5 years, really growing tenfold in terms of the number of healthcare organizations that we serve here in Arizona. We have over 850 healthcare organizations that participate in our HIE, and that spans the gamut from all different types of healthcare providers to health plans, ACOs, and all different types of organizations. When the information blocking rule came out, of course, as an HIE, our business is to support, secure, and authorize information exchange among the healthcare community. So anything that can further advance and support that, we are in favor of. So philosophically, we do not believe in information blocking and certainly are in alignment with what the rule's intent is to advance in the healthcare industry. The rule came out right around the time that the pandemic was hitting our country, and so I think it's been a roller coaster of reviewing all these different regulations and ensuring that this important work gets in place for our organizations. So for Health Current, we started looking at the real true impact of this regulation on our organization and on our community, really evaluating it in more detail last summer after we got over the initial hump with all the pandemic response work we were doing. And I would say our effort is twofold. Certainly as a health information exchange, we, as an actor under the rule, we have evaluated and put in place new policies for all of our participants to ensure that we're in compliance with the rule. Actually, this week, we're going to be releasing a new HIE participant policy set to our health HIE participants that includes a no information blocking policy and updates to our permitted use policy and a variety of other things to ensure compliance with the rule. But the other area of focus for us is ensuring that the healthcare community is ready. I'm particularly concerned that healthcare providers of different size across our community don't necessarily understand the impact that this rule could have on them as an actor. And so we've actually developed information resources. They're on our website. They're available to anyone to really try and provide information both to the rest of the HIE community if it's helpful, as well as to the to our community here in Arizona. So we're doing a lot in that area. I also serve as the board chair for the Strategic HIE Collaborative, SHIEC, our national trade association for HIEs, and we've made all those resources available through SHIEC. And I put in a little plug. I think SHIEC's going to be working on some additional information blocking webinars coming up, both for its members and for the communities it serves. So always looking not only to figure out how we're in compliance with this rule, but also how we can make sure that our community is prepared and is ready for the compliance date in about a month. So excited to be on the panel and look forward to the discussion.
Thank you so much, Melissa. Amy.
Good afternoon, everyone, and thank you for attending our presentation today. So my name is Amy Warner. I'm General Counsel Privacy and Compliance Officer at the Register Rio, which is a HIE, which is an actor under the information blocking rule. And we serve 14 counties in New York State. We are one of the oldest health information exchanges in the country, and we're one of 6 health information exchanges across New York State, and they are all connected by a superhighway called the Shiny. So what our health information exchange does, we help facilitate exchanging data in order to support clinical care, population health, public health, research through our secondary use committee, and consumer engagement. So what we are is it's a secure mechanism to allow the safe exchange of data across our region, and while being very mindful of the privacy and security rights and protection of the data. So I'm also a member of the statewide privacy and security committee for qualified entities, of which the Register Rio is one, and they focus on the policies that affect all of the health information exchanges in New York State, with a focus on privacy and security, and again, focus on patient rights. So I'm very excited to be here today because a health information exchange is one of the actors that has to comply with this rule. And we want to address some of the challenges that affect health information exchanges, because we're really not set up to be patient facing. So I'm looking forward to some good discussion today, and thank everyone for having us.
Thanks so much, Amy. And last but certainly not least, Adrian.
Thanks, Alice, and good afternoon, everyone. Thank you all again for being here. My name is Adrian Ellis, and I serve as an advisor to CRISP and have been since 2017. CRISP is Maryland state designated HIE, but we also have the good fortune of providing technology services to other HIEs in the region, including West Virginia, DC, and recently Connie in Connecticut. I've been with CRISP since 2017, working on a lot of behavioral health focused projects, but also on all of the patient facing projects. So anything related to patient education. My background is as a patient advocate. That's actually how I came into the health information exchange space, was serving as the resident consumer advocate on all of the health information policy boards and things of that nature. And so I'm really excited to be able to be working at CRISP on info blocking as it relates to patient access, but also as it relates to, as Melissa said, CRISP is certainly in support of the goal of information blocking and increasing interoperability and increasing patients' ability to access their information. But as Amy said, there are a lot of challenges that we have in this rule. And so while there are benefits and we are looking forward to all of those, we are definitely interested in learning from our HIE partners about how we can overcome some of these hurdles. So excited to be part of the discussion today.
Thank you, Adrian. Thank all of you. As you see, I wasn't lying. It really is an all-star cast. I'm going to start by asking Devin if she wouldn't mind to level set a little bit for us and give a little bit of information on what the information blocking rule is and says and requires. My guess is if you're taking an hour of your day to spend with us, you know a lot about the rule, but just so that we're all on the same page, I thought a little context would be helpful.
Yeah, sure. I'm happy to, Alice. And I'm really going to give a pretty broad overview. That's a very meaty rule. I mean, again, if you're with us today, you've probably started to dive into it. You might have just recently started to dive into it, and that's okay. But there's a lot of detail to it. I won't go into that much detail, but just to set the stage, clearly health information exchanges are covered by the rule as entities that are required to comply with it. And the HIE definition is really more of a functional definition. So even if you don't have the term HIE or HIN in the title, if you are an entity that facilitates the exchange of data between two or more unaffiliated providers, and you're doing that for treatment, payment, and operations, then essentially you are an HIE, which means that really you're going to need to avoid taking an action or failing to take an action that is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic health information. And that really applies to sort of any EHI that might be requested for any purpose. I mean, I think we're going to focus more on patient access in this particular panel, but the information blocking rule is not a patient access rule. It is an effort to try to prevent the blocking of information by entities covered by the rule, which also include certified EHR vendors and healthcare providers. The other thing to know is that this is a set of rules where intent matters. There has to be a bit of a knowledge element. You can't kind of accidentally trigger an information blocking violation. If it's conducted by an HIE, if you're talking about an act or omission by an HIE or a certified health EHR vendor, then you have to know, or you should know, that the practice is likely to interfere. So you can't bury your head in the sand either. This is a know or should know. Providers, on the other hand, are subject to the rules, and they have a little bit of a higher standard with respect to knowledge. The provider has to know that the practice is unreasonable and likely to interfere with information sharing. The definition of EHI is electronic health information in the designated record set, which is the information that patients have the right to access under HIPAA. And for the first 18 months of the rule, it's limited to what's called the US CDI, which is the US Core Data Set for Interoperability, which is generally covers most of the data exchanged by an HIE, although we could talk about whether there's some gap there with respect to the information blocking rules. Is this a per se disclosure law? Does this mean that, you know, if it's information blocking and someone comes to you and says, I want health data for X purpose and you have to give it to me, it doesn't actually work that way. It's more of a facts and circumstances test. And for sure, you're only, you know, required to respond to requests that the law would allow you to respond to, first of all. And second of all, there are also 6 different exceptions in the rule where ONC was required by Congress to establish six reasons for which information, you know, you're not information blocking if, for example, the reason why you're not sharing data is due to an existing privacy law, like the patient needs to consent and the patient hasn't consented, or there's a security issue in terms of risks to your system, or there's the possibility that the patient might be harmed by the data, or someone will be harmed if the data is released. Infeasibility is another big one that we should dive into. So it's part, I think, of the challenge for HIEs in implementing these rules is that is sort of, you almost have to go through each request on almost a stepwise basis, or at least have categories of requests. You have to say, here's how we're going to handle these, and here's how we're going to handle those. And I think we have exceptions in this particular circumstance, but not in others. So that's part of the challenge is the sort of uncertainty. Again, it's not a sort of per se disclosure rule. It's more one of, we don't want to be in a situation where we're found to be information blocking. So we have to really have a much more mindful process on how we're going to deal with the types of requests that are likely to come to us for data. So I'll stop there because that's about enough of the detail, I think, for us to really dive in and talk about how each HIE is navigating the space.
Thank you, Devin. And I think that sets up my first question really beautifully, because it's clear even from listening to that fairly high level brief overview that it's a complicated rule with not necessarily simple legal analysis. And I know I've been part of a number of webinars and conversations over the past year about the legal implications, legal analysis of the rule. I'm wondering, though, what our panelists would say have been the greatest implementation challenges. We're almost at go time. The compliance deadline is, I believe, April 5th. Yep. You know, earlier, Melissa, you mentioned updating your various policies. Devin and Amy, you both touched on the patient access component. Given that we all support the free and secure and private exchange of information, and we want patients to have access to their data, so the intention behind the rule is certainly good. What have been some of the sticking points or challenges in actually coming into compliance with it for you?
I would say that one of the most difficult challenges we have to address is properly vetting or the identity proofing requirement. And in the New York State, in addition to following federal regulations, the New York State regulations also require before giving patients access that the RIOs or health information exchanges must properly authenticate. So, and because of the fact that we're not really set up to be patient facing, we're looking and exploring different ways to manage this, including the possibility of using vendors to perform this service.
I would add, in addition to that comment, just trying to start navigating how the request will come into the organization. I appreciated what Devin said about, we've actually had entities or requests of our organization say, well, you have to give it to me or it's going to be information blocking. Well, maybe, but we actually have to train our workforce to know how to respond to those requests. And it's not going to be a one size fits all. It's going to actually be looking at going through that stepwise case by case consideration in alignment with robust policies that we've updated, in alignment with Arizona state law, and identifying in the construct of the regulation what our responsibility is. And certainly as an HIE, we want to be in compliance, but it's not an easy, you have to give this to me or you're going to be information blocking. It really does take a fair amount of analysis. So in addition to considering some of the patient authentication details and potential barriers and how we actually overcome that, because that's extremely important. I think making sure that we have a workforce that when we start getting requests, either now or in April, that we know how to adequately respond and we know how to analyze the request to make sure that we're in compliance and really support the community and make sure we know what the obligations are of the other actors so that when we're requesting information on behalf of our participants, we're clear in the construct under which we're making those requests.
Yeah, so I would just echo a lot of what Amy and Melissa already said. CRISP actually has been working on at least the patient access part of info blocking since 2019. Our board felt it was really important that CRISP start thinking about patient access and directed CRISP to come up with a plan for patient access. And so in 2020, we actually convened a patient engagement and education work group and charged them with 3 things. Tell us how to do better patient education, tell us how to better engage with patients, and tell us how to come up with provide a plan for us to actually provide access to patients to their CRISP data. The board eventually approved that work group. We had quite a few meetings. We had privacy and security experts, patient advocates, and healthcare providers, all members of that group. So we had a lot of really robust conversations about, Alice was part of those conversations about providing patient education and access and how those things work together. And we're still struggling to get that implemented, right? So that board approved policy went into effect at the end of the year last year. And so we're still figuring out the technology challenges to accepting the requests for patients. What are we going to do? How are they going to get access? In what way, what manner are we going to provide them their access? We're excited about working with the third-party applications, but know that the rule does not allow us to only work with third-party applications. And I think to Devin's point and to Melissa's point about dealing with the requests as they come in and setting up a pathway to accept those requests specifically from patients. But then additionally, I think we're still struggling to figure out how we're going to establish that technology. We don't have a huge workforce of customer support staff to deal with a bunch of additional phone calls from patients. We're not a patient-facing organization. So we're excited about providing patients access to their information because we think it provides an opportunity to build even more trust as a trusted entity. There's been a lot of research to show that when patients can see what data is being shared, they are more comfortable with that sharing. And so we are excited about that part, but there are still a lot of challenges related to the technology, the privacy and security. I cannot echo enough the patient identity validation and how critically important, but also challenging that is. We're excited to be working with our state agency, our Medicaid partners, to help them provide their patient to meet their requirements under a separate rule. And so we're hoping that we can use some of the same platforms and some of the same vendors so that we can provide Medicaid enrollees and CRISP patients in Maryland, some of whom may be the same with a streamlined approach. So we're hoping that we can leverage some of the resources and funding and technology that comes through that project for the CRISP patient access work as well. I would say that one of our other challenges has been is updating our policies and our participation agreement. We have to broaden our permitted purposes, and it is not. We're undertaking that task right now, and it's not an easy task to dig into that agreement and get everyone to agree what those permitted purposes should be. But we're excited to try to meet that challenges from the policies perspective as well as the technology perspective.
You know, the rules don't require HIEs to go out and buy new tech in order to sort of meet their information blocking obligations, or to make sure that they're not running afoul of them is probably a better way to put it. But at the same time, I could see how, like, leveraging, you know, if you really want to leverage the ability to use this as a relationship building exercise, that you might want to get some new tech. But it's, you know, that's definitely something that, you know, how do you figure out how to take an infrastructure that was built to allow your participating members, most of whom are probably paying subscription fees, to access through those pathways, to be able to say, well, how could we open that up in a way that would allow others to access in the same way? And does that even make any sense for us to do it? So I can see how that would be a challenge. On identity proofing, and we're getting a lot of questions about this. I feel like, coming from the voice of a patient-facing platform that hopes to be able to work with HIEs to provide access to our users, I think that's our responsibility. I mean, obviously HIEs have to trust us, and we would want to do that work in accordance with a particular standard that makes people comfortable. But I think that's something we need to do. You know, these are, if you think about whose customers are they, you know, at least at a minimum, they are the customers of the app or the service that is presenting the request. Again, for patients who have chosen one, fully recognizing that a patient might just knock on your door, right, and say, hey, you know, it's like, go fish, give me all your threes, give me all my data.
I think, Devin, you raised a good point when you talked about not having to buy additional or new technology, because I think we need to be mindful that most of the health information exchanges are nonprofits serving our communities. So I think that the ONC was mindful of this in creating this rule, that, you know, the HIEs are here to serve the communities, but they may not have the resources, you know, to get all this new technology and equipment. So I don't think that they wanted to impose an undue burden on them, but they want to give patients access. So there's a fine line.
And just to add on to that, I think we're also really sensitive. We don't want to duplicate any efforts or any money that's already been spent to provide really solid patient portals, right? So the EHR vendors and our healthcare providers who are participants who pay fees have already purchased patient portals. And so we do not want to duplicate those efforts. So we're also hopefully going to be working with some of those vendors to provide our information in those portals and provide a lot of options for patients so that they don't come knocking on our door, right? That's like the worst case scenario for us. Not even outside of COVID times, is having people show up at an office and say, give me all your threes. That is, so we, in terms of not building new tech, we are really trying to be really thoughtful about that, but we're also trying to be thoughtful about, is there a way to leverage technology to even accept requests, right? So to validate identity and accept the request that can then be considered if a patient doesn't want to use a third-party application. Tell you it would be a lot easier if our rule was the same as the Medicaid agency rule, where you just stand up the API and patients come with their application and get their data. But ours is a little different in that we have to at least consider all requests. And so one of the recommendations of our patient engagement work group was to figure out what, you know, can you build a simple technology that will allow patients to at least put in their requests for how they would like to receive their information, so that you don't have phone calls and people knocking on the door. And so we're thinking through that right now as well. Like, is there something simple we can build that's tied to identity validation that isn't seen as a hurdle that we can kind of leverage and then potentially also build upon as well, right? We don't want to build throwaway tech. We also have no idea the volume, which is really difficult for us to try to figure out, like, how many patients are going to be knocking on the door, how many are going to come with apps versus how many are going to come not with an application. And so we've really struggled with that to try to figure out resources and how many, how big this project is actually going to be, because we have no sense of volume. I don't know if anyone else on the panel has found any good research on, like, what's the volume going to be for, at least for patients.
In terms of the volume, in Arizona, we've had a state law for over 10 years that allows patients to have a copy of their information that's available through the HIE. I agree with all the comments around authentication because our process today is to validate the patient identity through the healthcare provider that's participating in the HIE. That will be our starting point for information blocking, but we are, the one thing I think the HIE community is great at is collaborating with one another and identifying best practices and leveraging different options that are available. So for instance, even out of our a new initiative we have around standing up a statewide advanced directives registry, we are exploring the electronic authentication options. I agree with some of the challenges. Some of the more robust ways are cost prohibitive to nonprofits like HIEs, but I'm particularly interested in even, the comments from the other panelists on the call today, because I really think we have to think creatively about how we can provide better patient access, how we can make it as seamless as possible. If we think healthcare providers have challenges with workflow, patients, I think, have probably even more challenges across the board in terms of how to navigate the healthcare environment and get access to their information. So how can we make that easier? We need to think creatively. And at least in terms of volume, back to your comment on that, Adrian, in Arizona, because we have that patient rights that allows access to copies, it's manageable and it's a fairly manual process today. So I think the question will be, how much is our communities and individuals aware of this regulation that gives them additional access options or opens the door for that, and then how many will come knocking on the door of healthcare providers or HIEs once the rule goes into effect.
In New York State, what we're doing is all of the qualified entities or health information exchanges, we have a privacy work group that I chair. And so we've been meeting and trying to discuss these matters because each region in New York State is a little bit different and volumes are going to be different. But we're trying to come up with a solution that makes sure that the patient's rights are protected and that the data is a secure transfer of the data. So that's what we're trying to do, because across the state, we realize that this is a challenge, but one that we need to overcome in about a month's time. So that's how we're handling it, where we have our work group and we're trying to come up with an idea that works for everyone.
Adrian, you talked about this patient education component that CRISP has been really focused on, and I've loved being part of that work. I wonder, HIEs are not traditionally thought of as the entities that are supposed to be informing patients about their rights of access, informing patients about the fact that when their data leaves a HIPAA-covered entity, it loses HIPAA protection, like the patients themselves do not enjoy HIPAA protections of their data once they have it. There are many patients who won't know what an API is or how they would even go about logistically getting their health information. I wonder what role you see your organizations or yourselves playing in that, or is it more of a participating entity provider role that should be taken on?
Yeah, that's a great question. I think one of the things that the COVID-19, among many others, taught me is that there's just so many misperceptions about HIPAA and what HIPAA actually protects, and that people do feel like if I tell you my health information, it's covered by HIPAA. And so I do think there's a huge, going to be a huge need to actually educate patients about that. And I do feel like as a trusted entity and as the state designated HIE, we are going to have, some role in that as required by info blocking, but then also just as a good state partner. We have, CRISP has a lot of information now on our website related to patients. And so I think we'll likely leverage the patient page we have to provide more information. I'm hoping that this is an area where we can work with our HIE friends to come up with some best practices that we can, so that patients are getting similar information, so that we're not all reinventing the wheel. I do think it is going to be really important to let patients know that the HIPAA protections end when you leave with it, the HIE, whether it's an app, whatever it is. We're going to be looking to things like the Karen Alliance and their best practices for how to notify patients about looking at the terms and conditions and the privacy and security policies of the applications that you use. So I'm certainly interested to hear other ideas as well, but that's kind of what we're thinking, because as I already said, we don't have a, I don't have a cadre of support specialists who are going to be geared towards patients. They do a great job of answering provider and participant questions now, and they know how to handle those. And so this whole new world of patients calling and asking questions, or heaven forbid, calling and saying, I use this application and now my data is everywhere, and Chris being the front line to those questions is concerning. And so the more we can do on the front end to try to be really transparent with patients about what it means to access your data, you have a right to access it, what does it mean, what it means when you take it with you, I think is going to be critically important. But I don't have the answer yet about how exactly we're going to solve the problem.
So here in New York, as a result of the final rule from March of a year ago, this Privacy and Security Policy Committee in New York State updated their policies to make sure that we are in support of and compliance with the information blocking rule. And they now require, it says HIEs shall educate patients or their representatives about the risks of the disclosure to such patient and prior to making the disclosures. And it also then goes down to say such education shall be based on analysis or recommendations of neutral third parties that evaluate these apps, such as the Karen Alliance, as Adrian mentioned. So here now we've got the requirement, and again, we're meeting with the health information exchanges across the state to try and come up with some messaging, because on one hand, we're required to provide this education, but on the other hand, we're not their legal counsel. So we need to make sure that we draw the appropriate boundaries. We need to comply with these requirements, but we also don't want to give the impression that we are representing the patients in making these careful decisions.
That's a good point. Back to this notion of sort of an expanded HIE role, that you're doing things now or required to do things, or exploring roles that you will now play that maybe you weren't set up to play, or didn't build your network in a way that that compliance with some of these requirements was immediately available to you. I'm wondering, how do you feel the business model of the ways that HIEs have been set up is affected by this rule? Very often HIEs, again, little nonprofits, were not set up to be these data utilities for their communities or states, and increasingly it seems like that's a role you're being asked to take on, and with all of the legal obligations that brings along with it. So I'm wondering, are you feeling from a business standpoint, there were a number of mentions of workforce challenges, and then each of you just keep saying, well, we have to do this, and we're learning to do this, and we're exploring this, and we're building this. It just seems like that is expensive, both from a staffing standpoint and financially, and I'm wondering how your organizations are handling that.
Well, I can take that one to start. So when it comes to our business, and I'm sure that Adrian and Amy will have a similar reaction. I mean, my perspective has always been that we exist to serve the community. So we go through very robust processes, very aligned with some of the work groups and councils and committees that have been mentioned, to work with our community and identify what that means in terms of the services we provide, what's of value to our community, and certainly compliance and ensuring alignment with regulations is part and parcel to that. But as Adrian mentioned, I mean, we off and on over the years, we have always had discussions around patient access to information and what that balance is between the different ways to make that information available And I particularly appreciated your comments around not wanting to duplicate the PHRs that were, really enforced and put in place through the meaningful use era, because I can remember back to that point, and I think it's an incredible opportunity for the HIE to provide patient access, as long as it's aligned with what provides value to the community, what the healthcare community supports. And so I just see this as one additional opportunity to support the community as a whole, which includes the healthcare providers, the entire healthcare spectrum of stakeholders, plus the actual community, the individuals that we serve. Because that is our intent as a nonprofit. Our intent is to serve individuals and to improve individual health and well-being. So I really think that this goes towards that end. I do think we have to think about how each of us has to think about how the different requirements for technology and ensuring the appropriate privacy and security of information, so that any individual's information doesn't get into the wrong hands unintentionally. It requires additional considerations around the privacy and security of the information, which then leads to technology considerations, which then leads to cost. So it certainly does impact the business model. But I've always found that if it's the will of the community to put it in place, then we can work collaboratively with one another to find the solution to make that work. So I think that this is just a stop on the evolution of HIEs, and I think it's an exciting opportunity to mature and for those and to lead.
I'm very inspired by that. Thank you.
I was too.
Yeah.
Yeah.
Thank you for your service, all of you.
It all out. I don't have the perfect answer, but I think it's possible to figure out a good answer.
Yeah, which is I think a great way of approaching the April 5th date in general, which is what opportunities does this bring, in addition to obviously the challenges which we are talking about. One thing that was mentioned is sort of stepping on the role of the patient portal and of the provider members of HIEs, who are usually the primary outlet for patients, both in terms of their questions, but also in terms of getting their data. And I'll tell you from citizens' perspective, wearing my hat of, helping patients get their records, the amount of data that has typically been available to individuals through their portals is pretty sparse. Decisions are made at the provider level often about what information is going to get exposed through those portals and when it's going to get exposed. And it is often far less than what the individual has a right to under HIPAA, and it's often far less than what they might be able to get from an HIE. So while I can sort of appreciate I don't think anybody's trying to disrupt relationships here, but I really like the way you all have put it in terms of serving the needs of the community in the best way possible, which would include the patients in some way, shape, or form.
Yeah, I couldn't agree more, but I would just add, I think we have one of the struggles as in the business model is that we have differing voices and differing stakeholders. And now we have a new stakeholder, which is a very important stakeholder. Obviously, as a patient advocate, one could argue the most important stakeholder. The patient is the one who's making decisions about their healthcare. But there are differing of opinions, and we decided not to really get into the legal analysis too much today, but we have already heard differing. I think, Melissa already pointed it out. People come and say, well, I'll get this under info blocking now. Well, maybe, but also there are differing opinions from the different provider organizations about what the exceptions mean, what they can provide, what they can actually decide not to provide or not to make available. And as our primary stakeholders, we have to also consider all those voices. We have to weigh all of those things and make sure that we're not, out of line for our business associate agreement, but also making sure that we are serving the community in the entire community. So I think that's also been a little bit of a struggle for us, is trying to think through the participation agreement. How do you align the permitted purposes, but also, make sure that clinicians and others still have the opportunity to use their preventing harm exception to make sure that patients aren't getting data too quickly in terms of what the provider who's making that determination feels they should have, which is also, we haven't really talked about that too much, but I'm worried that that could be even more of a struggle moving forward with the differing opinions and policy.
In New York, how we address that is we have our standing meetings with our stakeholders. We also have our board meetings, and we engage our community, which is comprised of the systems, CBOs, community-based organizations, patient advocates, providers, and try to address these because everyone has competing interests and different concerns. So we've been trying to, get feedback from the community so that everyone, well, we all have to comply, but we all have different comfort levels. So we're trying to work together with our community because we serve a great population and handle it that way. And in addition, we tried to be proactive and get ahead of the regulation. So we updated our data sharing agreement, participation agreement, the business associate agreements to make sure that we were in compliance because I just wanted to get ahead of it versus having to do that, after the regulation took effect. So we've done that, but I think really listening to the members of your community, knowing that you have limited resources, at least then you can try and all work together to find a common solution. Or try. I don't know that there's a solution yet, but we're trying.
I'm going to ask one more question, and then we have 30 questions in the Q&A box. So, but before we turn to as many of those as we can get to, I just wanted to ask, are there issues for you that you think are still not clear in the text of the rule itself, such that if ONC were to issue guidance or implementation guidance would be particularly helpful for you?
I think clarification on the exceptions and maybe more real world examples. So because it's a little gray in regards to whether something falls under one of the exceptions clearly or not. I know you have to do a thorough investigation and act in good faith, but I would appreciate additional guidance along that and the penalties.
As the non-attorney on the phone, I would say I would defer to the legal opinions on the specifics on the text, but I do think, to Amy's point, the really observing what will happen and what enforcement will be taken on certain real world examples will be absolutely critical going forward. So I think any guidance that can clarify open issues is helpful. And then just continuing to track and understand, there's just lots of opinions and perspectives out there about what could constitute information blocking and what might be enforceable. So understanding where the line is drawn and really keeping track of that going forward, I think will be important.
And a line in regards to what's a request, your whole file, partial file. So I would like clarification really on that as well.
Yeah, so I'll just agree with everything else as the other non-lawyer on the call. I don't want to get into the guidance of or get into the text, but the real world examples would be so helpful, as well as any kind of alignment or safe harbor provisions in terms of patient identity validation. I feel like this is an area where ONC kind of defers to HHS, who then is kind of releasing differing guidance, or, in their new NPRM, they're saying some things may be undue burden. And so what does that actually mean? And how does that align with the ONC rule? So working together with their sister agencies would be really helpful, so that really thinking about the real world of this is what an HIE has to do. What are the steps along the way? And then also to Amy's point of what is a request and what additional kind of checks and balances can we put in place for, one of the ones we didn't really get into today is, payment as a permitted purpose, which I know some HIEs don't have payment as a permitted purpose. And what are there kind of guardrails we can put around that, and where do the guardrails end and where does the info blocking start, right? So there have been some requests where it's well, I'm going to get this now because everything under HIPAA is allowable now, and that makes some folks very uncomfortable to view it that way. So any additional guidance there would also be really helpful, I think.
Yeah, and I would say that one of the things that I hear most from some of our HIE clients, as well as just generally looking out into the world and seeing what people are tweeting about, which is all of the HIEs on this call, it sounds like have done the work to sort of do some policy changes and to maybe amend some business associate agreements, but that can be a challenge, amending those agreements, because, you know, particularly if there are participants in the HIE aligned to that agreement who actually don't want to change the agreement, right? Then what is an HIE to do when their business associate agreement precludes them from sharing for different types of purposes? And I think that that's not as well answered by the regulators yet. I know they're working on additional guidance, but I think that among many other things, real world examples, some examples around identity proofing, I totally agree would be ideal. Having come from government, actually, it's really rare for them to say, do the following 3 things and you will be fine, in terms of, which is exactly what stakeholders want, right? Just tell me what to do, because I'm happy to do it. I don't want to run afoul of the law. I want to do this in the right way. But it is absolutely possible for government to recognize certain practices as being possible to, and I think that kind of guidance ends up being even more helpful because it is that kind of practical, this approach would work, and this approach would work, and this approach would work, as opposed, and then people can choose among the ones that fit for their organization, as opposed to, well, you have to identity proof because you don't want to breach data. On the other hand, you don't want to be unreasonably burdensome about how you identity proof. And so that leaves entities really kind of stuck in the middle with, okay, what are we supposed to do? Yeah.
There are a couple of questions in the Q&A box about unreasonable burden and what you all think might constitute an unreasonable burden for a data request.
That's something we could use some guidance on.
Yeah, I was just going to say, I think that dovetails nicely with ONC. I hope you're listening.
The content and manner exception, I mean, I don't want to dive too far down into the details, but if you haven't really mined the content and manner exception and you're sort of worried about requests coming in the door that are very particular and very hard to respond to because they're asking for something that is highly particularized in terms of type of technology or type of data, et cetera, should take a deeper look at that, because it gives entities covered by the rules some flexibility regarding how they make data available.
Adrian, you touched on this. One question says, the main concern I'm hearing from my members is around patients gaining access to their laboratory or other diagnostic test results before hearing from the ordering clinician first, which doesn't seem like it was a desired outcome of the rule, but can you speak to a little bit of that, maybe differing priorities between patients and provider participants, or any of you, not just Adrian?
Yeah, so I think this is one of the tensions that would be good to have some more guidance on, right? So the ONC did recently release some FAQs, and one of them specifically talked about the delay for lab results, and specifically called out that delay in lab results could be or would be likely info blocking, and so a blanket delay in lab results. And so that does make it difficult from an HIE perspective, because you know, the technology, I don't want to dig too much into the weeds, but not all lab results that we get are link coded in a way that we could easily parse them out and say, these are what our providers have said. These are the lab results that could cause harm if they are given to a patient prior to their ordering provider talking to them, and then give us that list and allow us to parse them out. It just really, we don't have a strong level of confidence because of how the lab results come to us. They're not always standard coded, that we can actually do that. And so we are still struggling with this one. We have actually had requests from some of our healthcare, this is one of the areas where there's differing of opinions from some of the participants on what could be a delay so that they can make a determination for whether or not something could cause harm. And so this is one area that we are actually still working on with our legal counsel about how we're going to address the lab results and the just generally test results, radiology reports, all of those things. There are some concern. I think this is an area where healthcare providers, I don't want to speak for them too much, but my experience has been they have differing opinions here. Some are much more open and put one of those lab results in right away. Others are not. And so I'm going to be interested to see how others deal with this from an HIE perspective, because this is definitely one that we're still trying to figure out.
I would add some perspective. Several years ago in Arizona, there was a push for broader consumer access to lab results directly from laboratories. So we're fortunate at Health Current to have a long-standing and strong relationship with our Quest Diagnostic subsidiary, which is Sonora Quest. And they actually went through a similar process to what you're mentioning, Adrian, to look at the scope of lab tests and actually work with the provider community, and have done a lot of work in the area of being able to provide direct consumer access to test results, considering the types of tests they are and when there could be additional sensitivities where a time delay from a healthcare provider to allow a healthcare provider to have conversations with the patients is more important than others. So, you know, diabetics getting a copy of their A1C levels and knowing what that means and all of that is different than maybe a more sensitive test result, oncology test result or something along those lines. So I think it's important to look to some of those experiences that other stakeholders may have had, and certainly to understand how that jives with the rule as written and any flexibility in there. Oh, you're on mute, Alice.
I'm back. I'm happy to say, and I hope the audience will agree, that we really covered a lot of the topics that were asked about here. So hats off to the panelists for being so comprehensive. One I wanted to ask was whether or not, we talked about patient identity proofing, but have you thought about how proxy access would be handled or approached when it comes to an HIE? I assume that's another one of those technical challenges that you're working on.
Challenging, and even for patients or their a representative requesting an audit as to who has viewed their information or where, if anywhere, they have consented. It's very challenging to, you know, how do you get proof of that? And then now you have the additional burden. You don't want to be seen as interfering with a request. So we kind of handle those on a case-by-case basis to make sure that we properly authenticate. And again, it's been a little bit more challenging in the era of COVID. You know, prior to that, sometimes people will come to the office with maybe a court order or guardianship, but it's been very difficult the past year.
Yeah, I'll just agree totally. I think this one is one, you know, we have to solve just general patient identity validation first, and then figure out the proxy, and, you know, because you've got to validate the identity of the proxy, and then you've got to validate that they have the relationship. And so I think that this is likely for us, at least, to be a really manual process at first, just because I don't see any easy technological solution to mandating this proxy. We're trying to figure this out also with with Medicaid, our state agency partner. We're trying to help them through this. And so I'm hoping to learn more from that project and some of the vendors that we have on the queue there for them. But yeah, I think this one is really hard.
Well, we are right at time. I could talk to you all either on or offline for hours more. But I think that everyone agrees, at least from the chats that I'm getting, that this was a really interesting and valuable discussion. And just want to say thank you to all of you, not only for participating today, but for the work that you're doing. You know, I'm going to put Melissa's answer to the question about the community service on a pillow or something, because I just really am grateful, as I know so many others are, for all that you're doing. And with that, I will say thank you also to the participants for joining us. We will try to answer any questions that weren't answered on the webinar offline afterwards. And I hope you all have a wonderful rest of the day. Thank you.
Thank you.